Femoral acetabular impingement occurs when the head of the femur does not have full range of motion within the socket. This abnormal contact with time can cause injury to the fibrocartilaginous labrum that lines the socket. The injury to the labrum can then continue to progress and result in degenerative joint disease that can result in arthritis. Impingement can present at any time between the teenage years and middle age, but it usually occurs in young athletic patients and presents with a slow onset of groin pain that may start after a minor trauma. Signs and symptoms include that during the initial phase, many patients first notice an intermittent pain in the front of their hip or groin area. The pain may become worse with excessive demand on the hip from physical activity or after prolonged sitting. Walking uphill is found to be difficult. The pain can also be a consistent dull ache with or without a catching and or sharp popping sensation. Pain can also be present along the side of the thigh and in the buttocks. There are two distinct types of this impingement based on the pattern of injury to the labrum: a cam impingement or a pincher impingement. The cam impingement occurs when a larger abnormally shaped femoral head is jammed into the acetabulum during normal range of motion. This jamming results in tearing of the labrum and or pulling the labrum away from the rim. The tear often occurs in the top front part of the labrum and is most commonly occurring in young active male patients. A pincher impingement results from abnormal contact between the rim of the acetabulum and the femoral neck. The abnormal contact is mostly the overcoverage of the femoral head. When diagnosing range of motion wise, there will be limitations in all ranges, both active and passively, of hip range of motion. A special test that is used is the labral anterior impingement test. In performing the test, the examiner flexes the patient's hip to 90 degrees and then places the hip in about 25 degrees of adduction. The examiner then medially or internally rotates the hip to the end range and is considered positive if anterior hip pain is produced. X-ray and MRI really play an important role in diagnosing FAI. The X-ray can reveal an excess of bone on the femoral head or neck and on the acetabular rim. The MRI itself can reveal fraying or tears of the cartilage and labrum. You will see a special MRI called an MRI arthrogram that occurs for this diagnosis. Treatment for FAI is an open surgical procedure. This procedure removes the prominent area of bone from the femoral neck, which restores the femoral neck clearance to allow an impingement-free range of motion for the affected hip, hopefully ending the pain. All patients will remain toe-touch weight-bearing for 6 weeks for the labrum to heal, and range of motion of more than 90 degrees is going to be prohibited.